Good evening. Will the Standing Committee on Public Accounts please come to order? Before we begin our business today, I would like to inform the committee that we have received a membership substitution for this meeting only. This evening, Emily Blaschko will be substituting for Emily Dela Cruz. This meeting has been called to consider the following reports: the Auditor General's Report, eChart Manitoba, dated October 2018, Auditor General's Report, Forensic Audits, dated October 2018, Pharmacare Special Audit of Financial Irregularities and Controls, and the Auditor General's Report, Main Street Project Investigation, dated June 2021, and the Auditor General's Report, Follow-up of Recommendations, dated March 2020, eChart Manitoba, Pharmacare Special Audit of Financial Irregularities and Controls, and the Auditor General's Report, Follow-up of Previously Issued Audit Recommendations, dated March 2021, and that's eChart Manitoba, Pharmacare Special Audit of Financial Irregularities and Controls, and the Auditor General's Report, Follow-up of Previously Issued Audit Recommendations, dated April 2022, and that's eChart Manitoba and Pharmacare Special Audit of Financial Irregularities and Controls. And lastly, the Auditor General's Report, Follow-up of Previously Issued Recommendations, dated February 2024, and that's the Main Street Project Investigation. Are there any suggestions from the committee as to how long we should sit tonight? Emily Malloway?
Sit for an hour and then revisit.
There's been a suggestion that we sit for an hour and revisit. Is that agreed? Agreed and so ordered. I believe there was prior agreement that this committee had complete consideration of the following items without further discussion: the Auditor General's Report, Main Street Project Investigation, dated June 2021, and the Auditor General's Report, Follow-up of Previously Issued Recommendations, dated February 2024, regarding the Main Street Project Investigation. Does the committee agree to complete consideration of these items? Agreed? Agreed and so ordered. In what order does the committee wish to consider the remaining reports? Emily Nesbitt.
Pharmacare first, followed by eChart. Is that correct?
Okay, there's been a suggestion that we consider the Auditor General's Report on Pharmacare, followed by the report on eChart. Is that agreed? Agreed and so ordered. At this time, I will also ask the committee if there is leave for all witnesses in attendance to speak and answer questions on the record if desired. Is that agreed? Agreed. Leave has been granted. Before we proceed further, I'd like to inform all in attendance of the process that is undertaken with regard to outstanding questions. At the end of every meeting, the research clerk reviews Hansard for any outstanding questions that the witness commits to provide an answer to, and will draft a questions pending response document to send to the Deputy Minister. Upon receipt of the answers to those questions, the research clerk then forwards the responses to every Public Accounts Committee member and to every other member recorded as attending that meeting. We will now consider the chapters on Pharmacare, Special Audit of Financial Irregularities and Controls. Does the Auditor General wish to make an opening statement? The Auditor General.
Thank you, Mr. Chair. I'd first like to introduce staff members I have with me today. I'm joined by Jeff Gilbert, Assistant Auditor General, and Jacqueline Nye, Audit Principal. Mr. Chair, in November 2014, the Winnipeg Police Service notified Pharmacare of a potential misappropriation of funds. The police had an individual in custody who was in possession of a check from Pharmacare and was unable to provide a reasonable explanation for why they had the check. Pharmacare conducted a preliminary investigation and found an employee was entering unsupported transactions into the Pharmacare system, which resulted in illegitimate payments being issued to several individuals. In 2015, the former Minister of Finance requested that my office conduct a special audit of the Pharmacare claims process and the transactions made by a specific employee. This request, made under Section 16 of the Auditor General Act, was accepted. Our audit focused on payments resulting from the manual entries made by the suspected employee during the employee's entire period of employment. These transactions totaled $1.1 million. Mr. Chair, we determined that between 2007 and 2015, the former Pharmacare employee processed over $236,000 in suspicious payments without the proper receipts or supporting documents. These payments were generally of higher dollar amounts and processed repeatedly to the same group of individuals. Through our audit work, we found an internal control environment at Pharmacare with many significant gaps. This enabled the employee to process transactions with no support. These unsupported transactions resulted in payments being sent to several individuals. We made 5 recommendations that would help prevent similar issues from occurring again. We conducted our 3rd and final follow-up on these recommendations in 2022. We noted that as at September 30th, 2021, only 1 of the 5 recommendations had been implemented, that Manitoba Health forward our detailed audit findings to Civil Legal Services. I'd like to extend my thanks and appreciation for the cooperation and assistance received from the many dedicated employees of the former Department of Health and Healthy Living. I would also like to thank my audit team for their due diligence and hard work in completing the report. And I look forward to the discussion today on this report.
Thank the Auditor General for his opening comments. Does the Deputy Minister of Health, Seniors and Long-Term Care wish to make an opening statement, and could he please introduce his staff joining him here today? The Deputy Minister.
Thank you. So I'd like to start off by introducing Sandra Renaud, who is the Department's Chief Financial Officer, or Executive Financial Officer, sorry. My apologies. I'd also like to start by thanking the auditor and the auditor's team for the work that they've done on this audit, and appreciate the recommendations and the work that they've put into this system. As the auditor noted, or the Auditor General noted, this was a matter that was referred to them given the significance of the concerns, and this is an audit that we view as helping us to understand where there's vulnerabilities in a large volume transactional program that supports Manitoba's having access to low-cost medications. The non-insured benefits branch is under the oversight of the Insurance Division in the Department of Health, Seniors and Long-Term Care. This branch is responsible for the administration of the provincial Pharmacare program, as well as the residential charges for long-term care residents and the ancillary services program, which includes prosthetics and orthotics, the Seniors Eyeglass program, and the Manitoba Adult Insulin Pump program as examples. Pharmacare is a drug benefit program for eligible Manitobans regardless of age or disease whose income is significantly affected by prescription drug costs, and these costs are not covered by other provincial and or federal programs or private insurance. Pharmacare is a deductible-based system that is based on the total family income adjusted for the number of dependents in the family. Administration of the Pharmacare program occurs through the Drug Program Information Network, also known as DPIN. System. This system was developed and implemented in 1995, has been the primary method of service delivery for the Pharmacare program, both by the department as well as prescribing pharmacies. In 2018, as the Auditor General notes, they released a report on Pharmacare entitled Special Audit of Financial Irregularities and Controls that was in response to an incident in the Pharmacare program dating back to pre-2015. Since the initial report was released, the Auditor General has released 3 follow-up reports on March 2020, March 2021, and April 2022. The audit highlighted opportunities for improvement to internal processes and controls with considerations for DPIN enhancements to automate manual processes, and it noted the irregular payments over many years were made through manual adjustments in DPIN under the Pharmacare program that totaled more than $236,000. A total of 5 recommendations were made in the 2018 report. The department accepts and agrees with the recommendations in the report and has been working since the report release on addressing these recommendations through review of internal processes and controls to address the findings and enhancements of the DPIN system. The department has either implemented or is working towards addressing the recommendations outlined in the report, and work continues on updating policies to support implementation of the recommendations where appropriate. Since the release of the report, the Pharmacare Special Audit and Irregularities Controls, the department has referred the audit findings to Civil Legal Services, and as a result considers that recommendation to be resolved. The department has been updating and enhancing DPIN to build in automated internal controls for processing of manual transactions where it has made sense to do so. A cost-benefit analysis has not been completed. However, The department has completed many enhancements to the DPIN system over the past 7 years to reduce the potential for fraudulent activity and to build internal controls and applications for processing of manual transactions that are consistent with the intent of the Auditor General's report, finding, and recommendations. Some of these enhancements continue to be in progress, and the department considers this resolved. Ongoing and continuing enhancements to DPIN are expected and will never be fully resolved. We have implemented a supervisory review of manual transactions where the Business Administration Unit Manager reviews a sample of weekly claims to ensure appropriate documentation for processing is present. The non-insured benefits branch does not have sufficient resources nor supervisory staff to complete a review of all manual transactions. However, the Business Accountability Unit Manager and the Executive Director verification of these samples will provide sufficient oversight required to mitigate potential for fraudulent activity. Enhancements to the DPIN system have been made to document entries made into the DPIN system. Most manual adjustments, either reversals, adjustments, receipts, applications, deductible adjustments, and checks, already had a user ID attached to the transaction, and functionality has been developed that has allowed for the addition of an additional employee ID and a reason to document each manual entry relating to client expenditure adjustments are made in DPIN. Process automation has now been implemented when a client is a Canadian resident. Programming rules have been established where daily CRA income verifications load directly into the client's profile without manual intervention. When Manitoba Health and CRA information matches, the deductible is then automatically populated based on daily information that is received from Canada Revenue Agency. The department has recognized that both technology limitations and reliance on manual claims processing and adjustments will not eliminate the potential for fraud or error, and the department approaches to reducing allocation to address the recommendations in the OAG report is based on balancing the business risk with the financial and operational cost of implementing the recommendations fully as proposed by the Auditor General. The scope of the work does continue to evolve, and the department will continue to collaborate with its partners to define opportunities to address all of the recommendations.
I thank the Deputy Minister. The floor is now open for questions. Emily Malloway.
Well, thank you very much. And it sounds like you've made a lot of improvements on those recommendations. But what assurances do we have that a person like that could not repeat the same thing that he did, like get away with that amount of money over a 7-year period? Like, what is our certainty to know that all the changes you've made guarantee that that couldn't happen today?
Deputy Minister. So thank you for that question. I think that's I would suspect is the crux of the concern around the report is there continued vulnerabilities for an individual to repeat what was a known vulnerability that the Auditor General looked into. The response to that would be twofold. Primarily, or not primarily, the first would be the daily audits of the records to see what's being some of the transactions, so that we would be able to note irregularities far sooner than the ability to somebody to fraudulently process transactions in an amount of $238,000. So this wasn't a single transaction of $238,000, as I understand how this was done. This was a series of multiple transactions, small transactions that were occurring over a period of time that were related to a single individual going into the system with a single login point and adjusting an individual's deductible back to the beginning of the year that would allow for them to then reset their deductible limits. And there would be some, we assume, don't know for sure, because I wasn't looking at the police component of it, or any of those would be shared with an individual. So these were small transactions that were designed not to alert the system to a big transaction. So we would see these irregular transactions on a daily basis through the regular auditing. The other piece to it is as I referenced, was the individual was logging in singularly. One individual was making these transactions. There now requires to be a second employee ID logged into the system in order for those transactions, which will then indicate that a second person is aware of the manual transaction that's happening, and should increase the probability or reduce the likelihood that somebody is singularly doing these small transactions over a period of time.
Emily Malloway on follow-up.
Yeah, my follow-up question is that this software was quite revolutionary at the time. This was like the film and government bringing this in, and it was, I don't know whether it came out of Smart Health at the time, the program they had, but anyway, it was very, very good program at the time. So how has all the software changed over the years? Like, are we using the same system now? Or I'm assuming we're on a cloud-based system now, or no?
Deputy Minister.
So no, it is the same system. I appreciate you seeing it as a visionary system of the time, and it continues to be in 2025, 30 years on, the same system that's used. It's not a cloud-based system, it's an on-prem solution, more of a traditional build from that time. It has undergone a number and series of enhancements in that, so it isn't the same program. Obviously, it's gone through a number of enhancements just in working on different operating systems. So 1995, I'm not even going to try to remember what the operating system was then, but as we moved through various iterations of Windows, the system would have been updated to operate on those server systems, and at the same time, we would make program enhancements, functionality enhancements, including enhancements that came out of the audit itself to address some of the Auditor General's findings and recommendations. So yes, it's the same solution that was brought in 1995. It is technology that would be considered no longer best in class, but it underpins a program that processes in excess of $250 million a year in drug claims in a fairly efficient and effective manner. And we will continue to monitor its feasibility and effectiveness in that space. And like we do with all of our IT assets, both in health and government more broadly, there's a process by which we bring forward opportunities to rebuild or enhance, and our IT experts make determinations and decisions about where our greatest vulnerabilities lie and make those investment decisions about where to move forward. And at this point in time, it appears that our IT professionals believe that the system continues to have some life left in it, and we continue to operate with that as our solution. As I indicated, it's not just a solution that's operated by the Department of Health. It is also the system by which pharmacies transact with us. And a replacement of DPIN, while at some point may be a necessary requirement, would be a significant undertaking because it would require changes both at the department level as well as the individual pharmacy level. And the vast majority of those operations are private businesses, so we do need to respect, the costs and change management related to a system replacement at that level as well as ourselves.
Emily Devgan.
To the second recommendation, through the chair, but correct me if I'm wrong, I heard mention about automated internal controls. So I'm wondering if we're using the same system and that there were some technical limitations previously, how those were maybe reconciled in order to implement these new internal controls. If we could hear a little bit more about that.
Deputy Minister.
Thank you. So just confirming, when you refer to the second recommendation, is it the one that the department conduct a benefit cost analysis for making enhancements to the system to build automated internal controls? So some of those were complete. We didn't do it through a cost benefit analysis. We undertook what we understood to be or believed to be the most critical enhancements that needed to be required. The solution or the change enhancement stopped short of a full automation of the solution. That would have been a fairly expensive and costly undertaking. So we automated the areas where we believed there was greatest risk in the context of being able to do individual transactions or manual transactions for many of these things. So again, deductible resetting, rebates or reversal of transactions, those sorts of things that now require the second staff ID login so that there's a record of who's doing it, as well as that there's a confirmation that a second individual is involved in those manual reversals or transactions as opposed to those being automated through the system. Many of those automated solutions would certainly be beneficial, but would be in the context of a very large scale system replacement. It's certainly it's functionality that's been noted as a part of a potential system replacement, but it hasn't been built into a pathway for updating the existing system right now.
Emily Compton?
Chair, I have a question around user feedback in terms of how are the people who are using the system finding it? Were they consulted in the development for where these holes were identified? And in the rollout, you know, talking about the practical application, many pharmacies, for example, are private businesses. Has there been pushback with second login required, you know, additional task component? How has that been received? And also, have there been identified catches that, you know, the second login and stuff applied to be filling those holes? Have we actually found that they've been working? Do we know?
Deputy Minister?
So thanks. No, I appreciate the question around staff feedback, and I can't comment at the time as to whether we did an engagement, a survey, or anything around that with staff about what would work for them. From that perspective, I would certainly like to think it did, because that would be certainly a best practice. Any sort of system change or a change management process, those that are using the system should be engaged and consulted in that. Development. But certainly in terms of your question around the feedback in terms of today's utilization of it, we haven't heard any concerns from staff with respect to the second login or the additional steps that are around that. That could be a function of it's been 5 or 6 years since they've had to do that, and it's for most of the staff, it's what they've always known. There's a fairly high staff turnover rate in the Pharmacare program. It's lots of clerks, and we like to see our staff elevated into more senior positions, so they do move into the department, and we bring new individuals in, and over this period of time, most people just have probably accepted that this is the way we do the work, and they wouldn't know any different. In terms of the additional catches, I'm just going to check with Sandra. I'm not aware of any significant fraudulent activity, so that's either an indication of there's enough deterrence in the system that people feel that there isn't a means to do what was done before, or we are catching small ones when they're happening before they get to be too big. But certainly I can follow up with department to see if there's been any significant catches that we were not aware of. But I think the sense is that we haven't had any significant indication of fraudulent activity. Is a good sign that people are aware of the controls, they're aware of the fact that the audits are happening, they're doing what audits are intended to do, which is to discourage inappropriate behaviors and actions, because you may get caught on that front, and as a result, we're functioning in a place that's better than it was in 2018.
Hearing no further questions or comments, I will now put the question on the Pharmacare Special Audit of Financial Irregularities and Controls chapters. Does the committee agree to complete consideration of the chapter Pharmacare Special Audit of Financial Irregularities and Controls within the Auditor General's report, Forensic Audits, dated October 2018? Agreed? Agreed. This chapter is accordingly completed for consideration. Does the committee agree to complete consideration of the chapter Pharmacare Special Audit of Financial Irregularities and Controls within the Auditor General's report, follow-up of recommendations dated March 2020? Agreed. This chapter is accordingly completed for consideration. Does the committee agree to complete consideration of the chapter Pharmacare Special Audit of Financial Irregularities and Controls within the Auditor General's report, follow-up of previously issued audit recommendations dated March 2021? Agreed? This chapter is accordingly completed for consideration. Does the committee agree to complete consideration of chapter Pharmacare Special Audit of Financial Irregularities and Controls within the Auditor General's report, follow-up of previously issued audit recommendations dated April 2022? This chapter is accordingly completed for consideration. We will now consider the reports on eChart Manitoba. Is there leave for a brief recess while the staff from Shared Health prepare for questioning? All right, we will now briefly recess. All right, we will now consider the reports on eChart Manitoba. Does the Auditor General wish to make an opening statement? The Auditor General.
Thank you, Mr. Chair. I'd like to introduce the staff I have with me today. I'm joined by Wade Bowe-McGuire, Assistant Auditor General. In Manitoba, personal health information is stored on a number of electronic systems, each with their own clinical objective. Launched in 2010 by Shared Health, formerly eHealth, eChart pulls the information together from many of these systems, giving authorized health care providers quick and easy access to their patients' medical histories. Authorized users include physicians, nurses, administrative staff, and other healthcare professionals. In our 2018 audit report, we wanted to see whether Shared Health was sufficiently managing the risks that could result in eChart's intended benefits not being realized, unauthorized access to private health information, and eChart being unavailable when needed. We found that Shared Health needed to better manage the risks that might prevent it from achieving eChart's intended benefits. We made 5 recommendations for improving their management of risk, and note in our follow-up report that all 5 recommendations have been implemented or resolved. At the time, we also found several weaknesses in eChart's access controls that could have compromised the confidentiality of Manitobans' personal health information. For example, we noted that more than 87% of eChart users could access personal health information of any Manitoban, and that eHealth's monitoring of user activities had gaps. Given the high percentage of users with full access to eChart, there was a heightened need to effectively monitor for inappropriate activity. Finally, we found that eHealth had good practices in place to back up and restore eChart's data. However, eChart's disaster recovery plan was not complete. This report included 15 recommendations in total for Shared Health to better manage the risks associated with operating eChart. In our April 2022 follow-up report, we noted that 3 recommendations are still in progress. I'd like to extend my thanks for the cooperation and assistance received from the many dedicated public servants we met with during this audit. I'd also like to thank my team for their due diligence and hard work in completing this audit. I look forward to the discussion.
I thank the Auditor General. Does the Interim Chief Executive Officer of Shared Health wish to make an opening statement, and would he please introduce his staff joining him here today?
Good evening, and thank you for the privilege to present to the Public Accounts Committee.
Sorry, Mr. CEO. Just need to recognize you for the purpose of Hansard. So go ahead. You have the floor.
Thank you very much. Good evening, and thank you for the privilege to present to the Public Accounts Committee and respond to questions related to Shared Health's completed and ongoing work related to the following Auditor General's reports. eChart Manitoba, dated October 2018. Follow-up of previously issued audit recommendations dated March 2020, and follow-up of previously issued audit recommendations dated April 2022. My name is Chris Christodoulou, Interim Chief Executive Officer of Shared Health. I'm joined today by Christine Paulette to my right, Executive Director of Clinical Solutions, and Kevin Holochuk, Director of Cybersecurity and Chief Information Security Officer of Digital Shared Services for Shared Health. I would like to extend my appreciation and gratitude to the Auditor General and the Office of Audit Professionals. I want to acknowledge their professional and collaborative relationship with Shared Health and all our staff. On behalf of Shared Health, I want to acknowledge the findings and recommendations contained within the audit reports. I will speak today to the status of our response to a number of specific recommendations with my colleagues in attendance with me, and look forward to the opportunity to respond to any outstanding questions. As indicated by the Auditor General, since implementation, we can inform you that 99% of hospitals in Manitoba, 96% of nursing stations, and 87% of primary care sites across Manitoba are covered by the eChart system. It is integrated into over 20 clinical source systems and receives from these systems in excess of 6.5 million messages per month, and eChart information is in excess of 10 million access points per year. The eChart audit published in 2018 examined whether Manitoba eHealth was sufficiently managing the risks as outlined by the Auditor General in 3 categories: realizing its intended benefits, ensuring its information is accessed only by authorized individuals, and ensuring that it is available when needed. The key findings as outlined by the Auditor General included the risks of not achieving eChart's intended benefits and the need for those to be better managed. eChart access control should be strengthened, and good practices be put in place to ensure eChart's availability. To address concerns identified in the findings, the Office of the Auditor General provided 15 recommendations as outlined. 5 of those were linked to define and better manage the risks of not achieving intended benefits. 9 of those were for strengthening eChart's access controls, and 1 recommendation defined for ensuring eChart's availability. Progress on addressing the audit recommendations was subject to 3 follow-ups as outlined. The 2022 status update provided by the Office of the Auditor General indicates that approximately 53% of the 15 recommendations were considered to be addressed, as shown in the status overview. 7 recommendations with the status of implemented or resolved, 1 recommendation with the status of action no longer required, 4 recommendations with the status of do not intend to implement, and 3 recommendations with the status of work in progress. Since the last status update, progress in addressing the recommendations has increased to a compliance of 73% through the implementation of 3 recommendations, including 2 of the 4 previously defined as do not intend to implement. Planned work for the fiscal year of 2025 and 2026 will address further recommendations, bringing our progress to 80% in addressing the 15 audit recommendations. I will now provide an update on addressing the recommendations in each of the categories. The first 5, as the Auditor General outlined, have been addressed. Recommendation 6, which indicated that we recommend that eHealth update the eChart user access guidance to specifically link healthcare roles to appropriate eChart views and establish a process to handle any necessary exceptions identified by the sites, was originally, as of 2021 September, a do not intend to implement. The update we can provide is that Shared Health's current site onboarding practices provide guidance to ensure appropriate eChart views are defined for the healthcare roles at the site. Recommendation 7, we recommend that eHealth, as part of the periodic audits of user activities at sites, obtain assurance from each site that eChart users have signed their personal health information confidentiality pledges. This is no longer required. Recommendation 8, we recommend that eHealth ensure that consultant staff attend personal health information training sessions and sign confidentiality pledges. This is implemented and resolved. Recommendation 9, we recommend that eHealth ensures site privacy officers are trained upon implementation of eChart or upon being assigned to this role and periodically thereafter. The status of September 2021 was do not intend to implement. The latest update is that revisions to shared health practices have addressed this recommendation. Recommendation 10, that eHealth define and communicate minimum timing requirements for sites to request removal of eChart users that no longer require those privileges. The original status update indicated do not intend to implement. The update is shared health has taken actions to implement this recommendation. 11, we recommend that eHealth requires sites to certify the quarterly user account management report as reviewed and communicate any needed changes in user views and authorized users in a timely manner. Originally, this was do not intend to implement. The update is that Shared Health agrees with the value of the recommendation, and we will continue to explore opportunities to implement a technical solution to address the recommendation. Recommendation 12, we recommend that eHealth update the eChart audit methodology to include a site selection process that is both random and unpredictable, and B, that monitors users' activities through automated triggers and alerts. 12A has been implemented and resolved. 12B continues to be a work in progress recommendation. The update that I can provide is that analysis is currently underway with plans to implement the technical component of this recommendation after the eChart upgrade is completed in fiscal year 2025-2026. Recommendation 13, that eHealth, in collaboration with the Winnipeg Regional Health Authority Chief Privacy Officer, update the eChart privacy incident handling processes to clarify responsibility for patient and public notifications, has been implemented and resolved. Recommendation 14, we recommend that eHealth promptly implement the cybersecurity control recommendations presented in the letter of management. The status as of September 21 was work in progress. An update that I can provide is that Shared Health has addressed the cybersecurity control recommendations listed in the letter to management. And finally, recommendation 15, we recommend that eHealth develop, communicate, implement, and test a disaster recovery plan for their data, systems, and infrastructure, which would include eChart. This status as of September 21 was work in progress. The update that we can share with you today is that Shared Health will address this recommendation with the upgrade of the eChart scheduled for the fiscal year 2025-2026, and the upgrade will include new cloud-based hosting, which will include a full disaster recovery capability. We're now prepared to take questions on administrative-related items posed by the committee and any recommendations that we've commented on. We will endeavor to answer any and all inquiries here today. However, note that some questions may need to be taken as notice, in which case we will provide a specific response in writing. I will pause there. Thank you.
I thank the interim CEO for those opening comments. The floor is now open for questions. We have a question from MLA Malloway.
Thank you, Mr. Chair, and I'd like to ask you, then presumably at the moment, then all these health records are being stored on a server farm somewhere. Where is this server farm?
The interim CEO.
Thank you, member, for the question. I will confer with my team.
The interim CEO, go ahead.
Yeah. Thank you. The information is stored in servers in a data management center in Winnipeg that is operated by Digital Health Shared Services.
Emily Malloway.
And thank you, Mr. Chair. And so this year, or later this year, you're going to be moving all this information to the cloud. And can you name the software you're using? Is there a cloud-based software that you're going to be using? And then I assume you don't need the server farm anymore, right? So you'll be, what are you going to do then?
The interim CEO.
I will confer with my team, and thank you to the member for the question.
The interim CEO.
To answer the member's question, the Altera software solution is the product that we will be using, and the systems will transfer to this cloud-based system.
Emily Compton.
Thank you, Honorable Chair. As someone who has used these systems before, I have questions kind of through that user lens. I'm curious how much consultation with the people using the system, like on the wards, on the floor, has been done or plans to be done as the system evolves, in terms of direct feedback of understanding FIA needs, but also finding the balance of keeping things secure and functioning, as well as being able to use it quickly or, efficiently for the needs of serving our patients and clients and their families. And I know I haven't received, in the years that I worked on the floor, any sort of surveys or feedback on how are things working. Is that planned in the future to check in with the people using it?
The interim CEO.
I thank the member for the question. I'll confer to my team.
Yeah, go ahead, interim CEO.
Thank you. I'd like to request of the chair that Christine Paulette respond to that very important question on user feedback.
Ms. Mulland.
Thank you. Thank you for the question. We do have surveys that are sent out to authorized sponsors. Those are typically done.
Sorry, Ms. Paulette. I just wanted to recognize you for Hansard. My apologies. Go ahead. You have the floor.
Thank you. We do have surveys that are sent out annually to authorized sponsors. As far as feedback goes, when we implemented the solution, we did look for feedback, but we do encourage users to provide feedback generally throughout the year. As we do upgrades, we also look to involve user groups in testing the product and making sure it fits the needs.
Emily Compton.
Thank you, Honorable Chair. Kind of a follow-up to that in terms of like application. Have there been more notice, when someone's maybe not following their FIA protocol properly? Because it sounds like a lot of things, even from the Auditor General's report, more things have been implemented for that. Has that been identified as, I don't want to say catching people, but being able to mitigate, decrease inappropriate access of patients' information, things like that? Are you able to identify if that's happened?
If the executive director or the CEO, when you are prepared to answer, just feel free to raise your hand. I can recognize you at that point. Go ahead, CEO.
I'd like to thank the member for the question. I'll just confer with my team for a moment.
the interim CEO.
I'd like to thank the member for that question. I have in previous roles with the Shared Health as provincial anesthesia specialty lead and head of the Department of Anesthesiology, Perioperative and Medicine, being involved in the processes that are undertaken if there's inappropriate eChart access. There are routine audits that are undertaken. There are internal controls that can determine when individuals are accessing information that is not authorized within their user role. And in those circumstances, those individuals have been addressed from a performance feedback and or a disciplinary process that's led forward to deal with those violations.
Emily Compton.
Thank you, Honorable Chair. Oh gosh, I had it. My question pertains to, we have eChart, but we also have other electronic record systems. So like I come from St. Boniface, for example, but the Manitoba Renal Program. So we had multiple programs, multiple kind of record systems that we were working with. What are potential vulnerabilities that are being considered around the communication or lack of communication between these differing systems? Because I know there would be inconsistency in actual information. So in terms of patient health information being consistent between these different ones, there could sometimes be discrepancies. Is there plans to try and integrate the different systems to have consistent patient information along them, or to keep them fully separated so that, again, for just safety reasons, security reasons, there's no potential of overlap? Is there any consideration around that? Because I know clinical application can get cumbersome if you have a whole bunch of different systems that you have to access. So I'm just curious.
The interim CEO.
I'd like to thank the member for the question. I'll confer with my team.
The CEO.
I'd like to thank the member for the question. We'd like to take this question away. The scope is much larger than the eChart in and of itself. What I can share with you, being an active user of both the electronic systems at the facility that you reference, as well as an eChart user, is that you require username and password to access eChart through the integrated electronic clinical record that exists. So there is a username and password that's defined that has to be entered. But the scope is much bigger in terms of the integration piece, and we would like to take that away for further consideration to provide a response.
Emily Devgan.
Actually, my colleague sort of stole my question, so I'm going to maybe look at it from a different perspective, but the transition to cloud storage and I guess the progression of this system that we're using, does that present an opportunity to consolidate these other systems? Because just anecdotally, I know from those who I know who work in the healthcare system, there are some challenges with different systems and access, but perhaps down the road, that could be an opportunity and more of a question.
The interim CEO. I'd like to thank the member for that excellent and visionary, forward-looking question. I'll confer with my expert team here.
The interim CEO.
Yeah, I'd like to thank the member again for that excellent question. The purpose of eChart is to integrate multiple sources of information. Just give you two examples, laboratory and diagnostics information into one source of truth. And as to the question of does this pose opportunities in the future to better integrate solutions, the potential for that exists. But eChart in and of itself is a program that actually integrates many of the facets of information that puts one source of truth for clinicians, providers across the province. So whether you're in Flin Flon, Manitoba, or Winnipeg, you can access the same information in those facilities that I've outlined that have this system. Thank you.
Before we go into Emily Divgan's next question, 5 minutes to go before our agreed upon hour. Is there a suggestion? Okay, all right, so we have 10 minutes. Okay, Emily Divgan.
I won't take all that time. Just to go back on the question that my colleague asked earlier regarding the cloud system, is that the system that we're using, is that based out of Canada, Manitoba? And just with regards to overall information security, is that system, how do I ask this question? Is it Canadian or is it American?
It's American.
Interim CEO.
I'd like to thank the member for a great question. I'll confer with my team.
The interim CEO.
Thank you again, member. The company that we're contracted for our cloud-based services is a Canadian company.
Emily Malloway.
Well, thank you, Mr. Chair. And I recognize that there's the same kind of problems that you have, other organizations have as well. And in the past, like Autopack, whether it's a server farm or cloud-based or whatever the point is, that there are been instances in the past where people are employed with agencies and they decide to look up famous hockey players that, check on what kind of cars they own and stuff like that. And we know that can happen with the healthcare system too, right? And I know that you have to draw some lines somewhere, but if you go into a walk-in clinic, you'll find that the doctor there might only have access to a limited piece of your medical history when you would like them to have more, right? But the danger of that, as you know, is that people can be shopping around looking at the whole thing. But I am concerned about this security issue because right now you're on a server farm. Like the Autopack server farm is not even in Manitoba, it's in Ontario. Is that dangerous? I don't know, but you say it's here, but at least I'm a little more confident that you're telling me it's on a server farm and it's here. It's backed up onto there. But once it gets into the cloud, I don't know where it is. You can tell me it's a Canadian company, but maybe it's a Canadian company today, but maybe a week from now it's going to be, another country's going to own it. As far as I know, cloud-based systems are almost 100% American, but, so I'd like you to comment on that. I mean, it's not really saying anything's gone wrong here, but there's certainly, the more you go cloud-based, to me, the more chances you're taking that your information is going to end up and especially with AI, who knows where this is all going to end up at the end of the days.
The interim CEO.
To address the member's question, I'll confer with my team.
Just a general reminder to members of the committee just to direct questions and through the chair. The interim CEO.
Thank you again, member, for that question. We are aware that the data servers that support the cloud are located in Canada, but we will have to get back to you on the specific locations of those data centers. And they're all protected based on industry standard security protocols.
All right. Hearing no further questions or comments, I will now put the question on the eChart Manitoba reports. Shall the Auditor General's report, eChart Manitoba, dated October 2018, pass? This report is accordingly passed. Does the committee agree to complete consideration of the chapter eChart Manitoba within the Auditor General's report, follow-up of recommendations dated March 2020? Agreed. This chapter is accordingly completed for consideration. Does the committee agree to complete consideration of the chapter eChart Manitoba within the Auditor General's report, follow-up of previously issued audit recommendations dated March 2021? This chapter is accordingly completed for consideration. Does the committee agree to complete consideration of the chapter eChart Manitoba within the Auditor General's report, follow-up of previously issued audit recommendations dated April 2022? This chapter is accordingly completed for consideration. So I think we skipped, yeah. Before the committee rises for the day, I would ask that all members please leave behind their copies of the reports so that they may be used again at future meetings. The hour being 8:01, what is the will of the committee? Committee rise.